Okay, so let's start. It's a great pleasure to welcome all of you here in Erkner and in the digital room. And it's a great pleasure to have Karen Clay with us. I hope you can hear us, Karen?
Yes, I can.
Okay, yeah, that's great. We have an advanced new technology, so we are a little bit excited if everything will work with this hybrid event that we are having today. I will do a short introduction and then we will listen to Karen's keynote. I'm Christoph Bernhard. I'm a historian and I'm head of the research area Contemporary History and Archive in the IRS here in Berlin-Erkner. The Spring Academy, which has brought you here in a way, is a series of annual events which offers 4 days of scientific dialogue, encounter and teaching for doctoral students and postdocs. And it is in this context of the Spring Academy that we are having now this keynote. The general title of the series of the Spring Academies is Investigating Spaces, Current Theoretical and Methodological Approaches. And we have now the part 5 of this series, which is called Spaces of Infection. Last year, we had lively debates on the topic of spaces of crisis. And before, in 2019, topologies. So you can see we always take current major societal challenges and connected to major scientific questions and studies. In this year's Spring Academy, we reflect upon the most recent experiences gained during the COVID-19 pandemic from different disciplinary perspectives. We discuss the pandemic against the background of studies on other pandemics, and we give special attention to socio-spatial dimensions of such events. How do viruses spread in societies? What were social and political reactions? And how were and are social practices affected? These are 3 of the overall general questions that the Spring Academy will explore this year. And with regard to the topic of our keynote today on the 1819 influenza pandemic, some of you might recall that this pandemic and historical studies on the pandemic, like the ones that Karen has undertaken, became highly relevant at the beginning of the COVID-19 pandemic in Germany in March 2020. Around March 12, just before the general shutdown in Germany, the most influential medical advisor of the German government, Christian Drosten, publicly cited a study on the strategies of 43 US American cities in 1918-1919. I think you are working with this study too. And this historical study is said to have influenced the perception of Christian Drosten and indirectly the German government's decision to give priority to closing of schools. So you see how the study of this historical event even has influenced current policies in Germany. Sorry for just before introducing Karen for making two technical instructions. Please note that this lecture will be recorded, but not the discussion, so it's just a lecture. And secondly, I wanted to mention in advance for those of you who are participating in the digital Zoom room, please write any comment or question in the chat, but only with the word contribution. And you can start during the keynote so that we can include you then after the lecture into the discussion. Now I'm coming to the introduction of our speaker today, and it's really a pleasure and an honor to have you here. Karen Clay is a professor of economics and public policy at Carnegie Mellon University's Heinz College of Information Systems and Public Policy in Pittsburgh, USA. She also holds courtesy appointments of the Tepper School of Business. She's a senior fellow at the Scott Institute for Energy Innovation at Carnegie Mellon and affiliated as a faculty member at the University in Pittsburgh School of Law. And she is a research associate at the NBER. I must admit, I didn't know what this institution is, but I learned that it's highly influential because it's the National Bureau of Economic Research, which regularly publishes working papers, and many of the working papers you have published and then were published in journals have been published first there. Karen earned her PhD in economics at Stanford University and held academic positions at the Universities of Toronto, California Institute of Technology, and Stanford Law School. And she is member of the editorial board of the journal Explorations in Economic History and other editorial boards. Her main fields of research are environmental economics, energy economics, economic history, and health economics. When going through her publications, I saw many articles which are dealing with problems of urban environmental history. That's my personal favorite field of research. Also on sanitation, air pollution, public health, and other topics of economic and historical research. Amongst her publications, I want to highlight her book, The Evolution of a Nation, How Geography and Law Shaped the American States, with Daniel Berkowitz, published 2011 at Princeton University Press, and articles on urban, economic, and environmental history, like, I'll cite the title, Adapting to Climate Change, Evidence from Long-Run Changes in the Temperature Mortality Relationship in the 20th Century United States, in the Journal of Political Economy in 2016. And I could cite many, many more from your list, but I let it. As you could see, and as we will see in a minute, her public keynote today is entitled The 1918-1919 Influenza Pandemic, Health and Economic Impacts. It is a great pleasure, Karen, that you accepted our invitation, and the floor is yours. Thank you.
Thank you so much for having me. I am delighted to be here, and let me just get my slides going. Okay, so I was delighted to receive this invitation and to have a chance to talk about the 1918-1919 influenza pandemic, which I think is fascinating. I thought it was fascinating before COVID, and certainly COVID has added, I think, to the sort of interest in these kinds of topics. So what you see on the background of the slide is actually an electron microscope photograph of the reconstructed virus from the 1918 pandemic. And I think, one of the things that I find fascinating about this is just that it looks like something that you might see under a microscope in one of your science classes in high school. And yet this was an incredibly deadly virus and had sort of huge repercussions in terms of what was happening, certainly during the time period that it was impacting countries around the world. Okay, so in terms of the talk, I'm going to divide the talk into roughly two 30-minute segments. The first we'll talk about sort of an overview of the pandemic and some of the health and economic effects. And then I want to turn to some specific studies of spatial variation in mortality, in part because I think they're very interesting, but in part because I'm hopeful that they will have some resonance for you in terms of the kinds of research that you do. Okay, so let's go ahead and get started. as you are no doubt aware, the pandemic was brief but really severe. So unlike the current pandemic, which has stretched over a much longer period, the vast majority of the mortality occurs between October 1918 and January 1919. Estimates of worldwide fatalities have a very large range. And one of the things that I hope you'll take away from this is, interestingly, despite a century of time, there are a lot of things we still don't really understand fully about the pandemic. And so one of them, as you'll notice, is this incredibly wide range for worldwide fatalities. So one of the many things we don't fully understand is exactly how many people died. Now I'm going to talk about a paper by Barrow, and they actually come in even a little bit below the conventional estimates. He argues with his co-authors that influenza killed 2.1% of the world population. I think this is probably a little conservative, but what they rightly point out is this is the largest disaster in modern times. And so really important to think about it in that context. And they do some nice comparisons. So if the current pandemic were as severe as the 1918 pandemic, we would have 150 million deaths worldwide. Reported worldwide deaths are currently less than 7 million, which we know is a large underestimate because there are several countries which are reporting numbers that seem very low relative to other evidence. But in any case, even if we're at 70 million, so far, this pandemic has not been as significant in terms of mortality. This is from the Barrow paper, and what I wanted to show you was just the sort of incredible variation in across countries in the death rates. So in Germany, the death rate was a little less than 1%. In India, it's estimated, although I think these estimates are hard to verify, that it was around 5%. Indonesia is about 3%. The UK and the US are about 0.5%. And then because of the distribution of population, the aggregate death rate is estimated to be about 2.1%. Okay, so a lot of spatial variation at the country level. I want to talk a little bit about context, because one thing that's, there are a couple of things that are important and perhaps easy to forget. The first is that cities and countries routinely experienced high levels of infectious disease. And so while the pandemic was severe, it was not as sort of surprising as COVID was for us, I think. And the reason is because people just had a lot of experience with infectious disease. And so some of the kinds of things that were put in place, the non-pharmaceutical interventions, which we'll talk more about later, were not unusual. People had already had some experience with these. And so it was different in that dimension. The other thing is, of course, that the pandemic arrives during World War I. In some places, the war has greater impact than others, but I think one of the things that makes inference difficult in this context is separating out how much of it was deaths due to things like, malnourishment in the civilian population versus how much of it was deaths due to the pandemic. This figure is from New York City, and the reason to pick New York City is just that it has a very long time series. So we have a lot of data going back almost to the 1805 or something like that. And I want you to notice a few things. For much of the time period, if they're not having a major outbreak, reported deaths are around 25 or 30 per thousand. There are, however, these very severe outbreaks in the 1830s and again in the 1840s and 50s. New York makes changes to its water delivery system, and many of these cholera epidemics go away, but you can still see high levels of mortality and some epidemics that are occurring due to smallpox. And then suddenly things begin to change around 1890, and you see this secular decline in mortality, which we know is true in many other places as well, not just in New York City. And so indeed, there's this big improvement in terms of health, apparently. And so when you get to the influenza pandemic, it is a big increase relative to what it had been, it just in terms of the trend. But the thing I want you to notice is that in 1918, even with the influenza pandemic, it only raises the mortality rate to something like what it was in 1905, right? And so on the one hand, they were having a pandemic. On the other hand, the death rate is not too different than it was, not all that long before. This is from a paper by Jorda et al. That we'll talk about later. But one of the things that they do is they bring together and have this nice graphic with the Cirillo-Taleb estimates of 19 major pandemic events. And so starting with the Black Death and Spanish flu, and then a whole variety of others. And so these are ordered based on the central estimate. So the highest central estimate is the Black Death, followed by Spanish influenza, the 1918 pandemic, and then a variety of others. The other thing that they do, because these of course occur at very different times, is they rescale them to the 2020 population. And what you can see then is, of course, the Black Death looks even worse. But it makes it easier to compare the magnitudes of some of these pandemics. And so what I want you to notice is that people would have had experience, right? And many of these pandemics are in the 1800s. Some of these are in the 1900s and actually follow the Spanish flu. But the main point here is just that there were pandemics, there had been pandemics in the recent past, the Russian flu pandemic, for example. And so people were familiar with pandemics and had experienced them. In contrast, I think for COVID, the most recent pandemic was swine flu. And it does make the 19th worst pandemics, but it was nonetheless not a very long-lived and not nearly as severe as something like the Spanish flu. We also have the Asiatic flu in 57 and the Hong Kong flu in 1968. But after 1968, really there was this long period in which we don't have major pandemics, with the exception of swine flu, until the current pandemic. And so I think the population, again, was sort of not used to these kinds of things. And so I think made the transition a little bit more complicated. Okay, so what do we know? We know the pandemic was caused by the H1N1 virus, and that the vast majority of individuals lacked immunity to the virus. There's some speculation that some elderly people actually did have some immunity, perhaps because of the Russian flu, but I think the evidence on that is complicated. In terms of the fatality rate, it's much, much higher than seasonal influenza, right? So that turns out to be, of course, incredibly important. It's very contagious and has a high fatality rate. So this is from the US Center for Disease Control. And so we have, the US entering World War I, but more importantly, we have the pandemic in 1918 and 1919. And then some of the subsequent pandemics that we've already mentioned, 57, 68, and 2009. But the thing I want you to sort of notice here are actually down below. First of all, it's not until 1930 that we first isolate and determine that influenza is caused by a virus. It's not until 1960, so there were already had been some work on flu vaccines. Flu vaccines were not ready in either 57 or 68, so they don't, they're not able to bring them up fast enough. And it's not until 1960 that there's this recommendation for annual flu vaccines. And then it's not until 2005 that we actually have a full genomic sequence for the 1918 pandemic flu virus. And so one of the things I think that's fascinating is that it takes science a very long time to catch up, right? And so if you feel perhaps frustrated with the pace of science during COVID, I think one of the things that's been striking during the current pandemic is how much faster they were able to, with the modern methods and the techniques that had been developed, how much faster they were actually able to bring online things like vaccines. And so again, this is just the picture that you saw in the background, and you know, just sort of, again, coming back to the fact that it looks like many other things you may have seen under a microscope, but certainly was incredibly deadly. So where did it come from? The origins are unclear, and again, you know, with the theme of things we don't know, somehow we don't know where it started. There's some evidence for Kansas, some evidence for France, and some evidence for China. Those are very distant places, and so clearly we don't know. The H1 virus had been circulating for some time. Different people are exposed to different viruses, as we'll see when we talk about the H3 virus. But the H1 virus had been circulating for some time. The thing that was novel was this recombination with the avian flu N1. And this is believed to have occurred sometime around 1915. And so it was this that you know, led to the development of what was initially a not very severe H1N1 virus, and then subsequent mutation led that virus to become much more severe. This is just showing as it sort of moves around the world, first in the spring, when it's actually much less severe, but it appears in the spring in various locations. It's moving around the world, and then really in September, October, November, December becomes really severe. The thing to note is that that first wave in the spring and summer had a fairly low fatality rate, and you'll see that that's going to be relevant when we talk about at least the US experience. The second wave hits in the fall of 1918, and that's the thing that we hear, you know, most about people sort of dropping dead in the streets and the bodies piling up. And then there is a smaller wave in the spring of 1919. And so this is showing you just from, you know, New York, London, Paris, and Berlin. And you can see that it looks like there might be something happening in June and July in some of these cities. You can see that they peak around the same time. London peaks a little bit later, but certainly New York, Paris, and Berlin are peaking right around the same time in late October, London in early November. And then we have data for London that goes further out. And so you can see the second wave in February. So one of the things that was so traumatic, I think, for people in terms of the Spanish flu was this W age distribution of mortality. And the reason it's traumatic is because we tend to think, both with seasonal influenza and with many pandemics, that the people who die are usually either the very young or the very old, right? And if you look at the distribution of people who've died in the current pandemic, it turns out that very young children in the current pandemic don't seem to be too impacted, but most of the mortality has been concentrated among the old and the very old. So the thing that was different, of course, is that there are a lot of prime-age people during the Spanish flu who are dying. And so that's different than many other influenza outbreaks. So why were they dying? Again, this is something we don't, I think, know as much as scientists would like to know. It seems to be related to a couple of things. First of all, prior exposure to other virus strains. So if you had been exposed to an H1 virus previously, then you had some often partial immunity. It didn't mean you wouldn't die, but it meant you were less likely to die. Whereas people who had initially been exposed when they were children to H3 had less immunity. And so people around the age of 28 had been first exposed to H3 and so had less of this partial immunity. The other thing that happened is because of the nature of this particular virus, it seems to have caused what's called a cytokine storm. So basically it caused the overreaction of the immune system. And so if you were young and healthy, that meant you probably had a young and healthy immune system, and therefore it was more likely that it would cause this overreaction, which would then itself contribute to your fatality. So this is just giving you the W shape. And so again, you can see, the very young were impacted, the very old were impacted, but sort of unusually, you have this big effect for people who are in the 25 to 29 age group, both for women and for men. And men, for whatever, again, biological reasons, seem to have been disproportionately impacted. Okay, so how did they respond? They responded by wearing masks and washing hands. So that technology was already known and widespread. Antibiotics had not yet been developed. And the reason this would be relevant is because many people, after they had influenza, developed bacterial pneumonia. And so bacterial pneumonia, had there been antibiotics and a way to deliver them, could have been forestallen, and so fewer people presumably would have died. Vaccines had been developed for other things, but had not been developed for influenza. And so medicine really had very little to offer beyond palliative care. So this is a picture of people in the Red Cross. They're all wearing masks and they're making masks for general distribution. And these are policemen in Seattle, Washington. And again, the thing to note is that they're all wearing masks. This is an advertisement from a newspaper. And this is right, a little after the peak, but certainly during the period of high severity. And so what is it telling you to do? First of all, you should notice this is a soap ad. And it says you should wash your hands before eating, when you come home from work, and whenever you come home from the street or come in from the street, and you should wash properly. And then there's this little insert that you can see that talks about Spanish influenza, right? And so the point here is just that people already knew about hand washing, but this is being reinforced even in the soap ads during the influenza pandemic. So what happened? Well, much as with some periods of COVID, the hospitals were overwhelmed. Temporary hospitals were established in a wide variety of settings. So for example, a church near my house in Pittsburgh was a hospital for influenza patients. Probably many other places near my house as well, but I happen to know about that church. Volunteers were found, including nuns, to work in hospitals and do community work. Needless to say, there weren't lots of people who wanted to volunteer, in part because people wanted to stay home and try and avoid getting the pandemic. getting influenza. The morgues were overwhelmed, and so if you read the contemporary accounts, the collection of bodies was slow, and the dead were buried in mass graves. So this is just a photograph of a temporary hospital, and so you can see that it's they've taken something that looks like it was probably a gymnasium, perhaps, and put a lot of beds, and so they tried to put up dividers. The other thing to notice is that both the patients and people who appear to work in this hospital all are wearing masks. Just to give you a sense of these temporary hospitals, this is a picture of some laborers who are digging a mass grave to bury the victims. Oops. We've already had reference to the fact that there were non-pharmaceutical interventions, and in fact that they influenced policy in Germany, which I hadn't heard before, but is nonetheless fascinating. So the timing and intensity of these interventions varied across locations. A lot of what we know is from US cities because of a very influential study of about 40 US cities, but I'm quite sure that you could do a similar study in many other locations. So the things they were using were isolation and quarantine, which were already well known in cities because of other types of infectious disease, including there had been a significant polio epidemic in the United States just a couple of years earlier. And so these were well known, but isolation and quarantine goes back centuries in terms of a strategy for preventing disease spread. There were also, in many cases, closures of schools and churches, bans on public gatherings. Again, just to reinforce that the population already was aware of these kinds of interventions because they were periodically imposed during other epidemics and pandemics. So this particular newspaper headline is from Seattle, Washington, talking about churches, schools, and shows being closed, bans on public assemblies, help bar influenza from Seattle. So a note from the state health commissioner, as well as the US Public Health Service. And so trying to give people some basic advice to avoid catching influenza. This is from the New York Times, and so talking about drastic steps taken to fight influenza here, closing orders for all stores except food and drug shops, hours for factories were fixed, so they were sort of trying to limit exposure as best they could in factories. Attempting to address transportation issues. The theaters were open in New York, and so they were trying to, again, sort of reduce the likelihood that people would get it by staggering some of the times and reducing density. And note here at the bottom, radical regulations necessary to prevent shutting city up tight, right? And so people were aware that if they could take some steps without completely shutting down the city, that would be obviously beneficial. The other thing in terms of people having experience is tuberculosis. Tuberculosis was one of the leading causes of death during this period. And so there was efforts of the Anti-Tuberculosis League and similar organizations in other places. People were made, already knowledgeable about keeping, for example, their bedroom windows open to increase ventilation and try and reduce the spread of not only tuberculosis, but also, the more recent influenza and pneumonia. And so all of this just to say that people had quite a bit of experience. Okay, so I want to talk somewhat briefly about the health effects. We've already talked about the fact that a lot of people died, but one way that people sometimes look at this is by looking at life expectancy. And so I'll show you some evidence on that. And then I think the other thing, and I think this is probably far more resonant than it would have been had I given this talk 5 years ago, is that there were chronic health conditions for a subset of affected adults and children. So today, of course, we're aware that some subset of people who get COVID will have long COVID, and some of those people, we don't yet know, how much those people will recover, and how many of those people will have some kind of lasting effect 10 years from now. So there's significant documentation on the fact that some people had sort of lifelong, or at least long-term effects of the flu. And then also in utero scarring. So the work of Doug Allman talking about the adverse effects of the flu pandemic on children who were in utero at the time that the pandemic hit. And therefore, some subset of those mothers got influenza and the adverse effects on those children. Okay, so this is just giving you life expectancy. And so one of the things you should notice, of course, is that this is a period between 1900 and 1940 of increasing life expectancy. So it's a bit below 50 initially, and it ends somewhere around 60 by 1940. So that's an incredible accomplishment. And you can see that in Denmark, for example, the pandemic was not particularly severe. And so life expectancy only goes down a little bit. For the average, you see a significant dip in life expectancy below what had been even in 1900. And then in very hard hit places like Italy, really an enormous decrease in life expectancy. And so just again, to sort of make the point that millions of people died, and you can really see it in the life expectancy numbers. This is from some work by Beach et al. And what they did was they looked at the Allman work, and one of the critiques of Doug Allman's work was that fathers of children who were born during the war were sort of more negatively selected. So they were less good in a number of dimensions than children who would typically be born. And the reason was because, of course, many healthy and successful men went off to war. And so the people who were left behind were often poorer or had other conditions, meaning that they were perhaps not as successful. And so even controlling for that in the Allman work, what you can see is that this cohort, so the cohort that was in utero during the pandemic, was more likely to not graduate from high school. They were more likely to be living below the poverty level, and they were more likely to have a disability that limited or prevented work. And so the main point being that the pandemic really did have lasting negative implications for children who were in utero around this time. The other thing I wanted to point out, because I think this is just fascinating, is this issue of persistence. So using data from 39 countries, Lin and Meisner show that countries with high mortality rates in 1918 had higher mortality rates in the early days of COVID, and they also show this is true for large US cities. And so I think we don't know why there's been so much persistence, but it's nonetheless just really interesting, because it does tell us something about pandemic preparedness and also perhaps other things. So some of the reasons why this would be true may be due to things like poverty or pollution, which we'll discuss in more detail later. But also things like, was the government willing to act? And was there trust in government? And so again, I think this is something that sort of warrants further analysis because it's so fascinating. But let me at least show you the patterns. So this is estimated flu deaths, and here they've just demeaned the data. And then this is average daily growth of COVID deaths in the first 60 days. And so you can see that it's positively correlated. The correlation is certainly not one. You can see, for example, that the US looks about average in terms of flu deaths during the pandemic, and certainly looks really bad in terms of the growth rate of the COVID deaths. Germany looks like it's sitting sort of closer to the middle in both dimensions. And then this is data from US cities, where again, we have excess deaths in the first 28 days in 1918 and during COVID. And again, they're certainly positively correlated. Okay, so now what I want to do is turn to the economic effects and talk about that for a few minutes. So the Barrow paper, which I mentioned earlier, uses annual panel data from 43 countries during 1901 to 1929. And they hold World War I combat fatalities fixed. And they show that a 1% increase in influenza mortality is associated with a 3% decline in real GDP per capita. Given that the average country had about 2% of the population die, it suggests that this resulted in a 6% decline in real GDP per capita. And so that's a significant decline in GDP, and we saw similar kinds of declines, large declines in GDP per capita during the very early phases of the COVID pandemic as well. The other thing that they look at is they look at both inflation, where the typical country had a 20 percentage point increase in the inflation rate, and a 14 percentage point decrease in real returns on government bills. They also look at stocks, but find the estimate is noisy. So the question is, well, okay, so things got bad. How long did it take for them to recover? And we have some data from Italy, Denmark, the US, and Sweden that suggests that the recovery was fairly rapid in the short run. And so that is good news, and perhaps not totally unexpected, given that it was a very severe but short-lived episode, at least during the peak of the pandemic. Now, one of the things I want to talk about, which I think is fascinating, and I highlighted or I italicized this because this is one of the studies that we didn't talk about in our JEL paper because it came out afterwards. But I think this is a really interesting study. So they look at pandemics from the 14th century to the present using data from Europe. So they were this was the paper that I showed you earlier, showing the pandemics spanning from the Black Death until the swine flu in 2009. And so one of the things that they can do is they can use data from Europe, where there's data on the real natural rate of interest going back a long time. And they can use data from Great Britain, where there's actually data on wages and GDP per capita as well. And they can compare what's the response to a pandemic versus what's the response to a war. And so what you see is, interestingly, in both cases, the initial response is sort of not necessarily all that rapid, remembering that this is over many pandemics, right? And so, but the longer run, so it's say 20 years, the natural rate after wars is still elevated at about 1%. And after 20 years from pandemics, it's actually below, it's lower than average by about 1.5%. You can also see that it looks like pandemics lead to sustained increases in real wages, at least in Great Britain, whereas wars have a little bit of a negative effect, but that basically goes away over time. It also looks like pandemics in the long run were beneficial in terms of GDP per capita in England. And so you can see that in 20 years, it looks like they've got about 5% higher GDP per capita. Wars, initially negative, which is what you would sort of expect, but looks like it's about getting close to zero at 20 years. And so the main point here is just to think about both the short run, and the short run, I think there was fairly rapid recovery, but the longer run is, at least in these data, very, very interesting. And so we'll see what it looks like after people, if we have enough time afterwards to look back at the COVID pandemic as well. Okay, so now what I want to do is just turn to spatial variation in mortality and talk a little bit about some specific papers that, again, my hope is will be actually perhaps useful to you in some way in your research. Okay, so before I talk about specific papers, I just want to, again, return to this idea that there is substantial spatial variation. So at the national level, we talked a little bit about Denmark versus India, for example. We're going to talk about 3 specific studies at the subnational level. So we'll talk about my work on US cities, Franca's work on Württemberg parishes, and then Aju's work on Indian districts. And I'll show you one last graph that just shows an example of a study that even looks at finer geographic levels. Okay, so this is from US cities, and this is from our study of 438 US cities. And so what you can see is, first of all, that mortality goes up from somewhere around 140, a little bit higher in 1917, up to above 190. All of these, by the way, are per 10,000. So many of the other studies are going to be per 1,000. So this would be 14 per 1,000 going up to above 19 per 1,000. This shows you excess mortality. And the thing you want to notice is that there are a bunch of cities that are not very hard hit, right? So they have pretty close to zero excess mortality, maybe a little bit higher than zero. And then there are some cities that are very hard hit. And so the question, of course, is going to be, why is there so much variation? And so that's going to be one of the puzzles to be explored. This is from Württemberg, and these are individual parishes. You'll see there are 1,763 parishes in the sample. And so again, some parishes get off quite lightly. They don't have any excess mortality or very low excess mortality. And then some parishes have very high excess mortality. Here, of course, each of these is representing the data differently. Here, what they're doing is they're going to compare British district officers and Indian district officers. And the first thing you want to notice is that there's really no difference between British district officers and Indian district officers in typical years, right? So there's a distribution, and some, have higher deviations from average deaths than others, but these two lines basically look the same. And then this is during the pandemic. And so again, we'll talk about the comparison of the two lines a little bit later, but the thing you want to notice is that there are a bunch of districts that have fairly low increases in mortality, and then some districts that have very high increases in mortality. And so again, a lot of spatial variation across these 3 studies. This is cumulative mortality. This is from a study of Chicago, and they're looking at census tracts, and they're looking at the 7th week of the epidemic in Chicago in 1918. And so you can see that, again, there are some census tracts that are relatively lightly hit, and then some census tracts that are very hard hit. So you see this variation not only at the national level and the subnational level, but even within cities. Okay, so is the spatial variation simply random? Certainly, I think that in the 1970s, 1980s, and maybe into the 1990s and beyond, there was a lot of sense in the literature that the spatial variation was just random, right? Some places just got hit worse than others. But there were also other candidate explanations. And one of the things that was sort of frustrating about the literature, and one of the reasons why we wrote our paper, which I'll tell you more about later, is that really it seemed that one should be able to sort out, at least to some degree, some of these candidate explanations. And so let me just tell you a little bit about them. The first was just this idea that if the pre-pandemic health conditions weren't very good, or there were a lot of people in poverty, that you would expect to see higher death rates, because people were just, if you're not as healthy, you're not going to be as able to fight off the influenza virus. Now, you might wonder, well, aren't pre-pandemic health and poverty the same? Because we have such a large data set in our particular context, we're going to be able to sort out pre-pandemic health, which is, you should think of as being a measure of the sort of local environment and a reflection of things like, is there a good, well-functioning water system, right, that's providing clean water? Poverty is going to be obviously related, but somewhat different. And so they're going to be cities that have similar levels of poverty, but very different measures of pre-pandemic health as measured by pre-pandemic infant mortality. And similarly, cities with similar measures of pre-pandemic health, but different levels of poverty. So we are going to be able to, in our particular context, look at both of these. In another possibility has been air pollution, and there's increasing work in a variety of contexts across animal studies as well as humans, looking at the role of air pollution in the spread and severity of influenza. So basically, it irritates the respiratory system, and so it makes it more likely that if you're exposed to the virus, that the virus will take hold. And the systemic inflammation that comes from air pollution also weakens the body. And so it also makes it more likely that, conditional on getting influenza, that you would die. Now, yet another set of hypotheses had to do with the timing of the onset. So in the US, it sort of spreads from the East Coast towards the West Coast. And so places, the argument was that places that got it later got a slightly less severe version. Related to that is this idea that if you're near military bases, so military bases tended to have a lot of people tightly packed under not necessarily super sanitary conditions. And so one of the things that would happen is it would spread throughout the military base, and then people would leave and go to nearby communities and spread influenza there. And so concerned that the military bases were also contributing to the variation. In terms of government response, we talked about non-pharmaceutical interventions. So maybe some of the variation is due to how the governments decided to respond. We'll also talk about other dimensions of state response, which are particularly important in the context of India, but may also be important in other as yet unstudied contexts. Okay, so our paper. I'm going to start with our paper. I'm going to spend a little more time on this paper and then go through the other papers, other two papers a little bit more quickly. We're going to use annual all-cause mortality data for 1915 to 1925 for 438 cities with populations over 10,000. People use all-cause mortality data often in this context and even today, in part because the recording of cause of death is not all that great, right? And you can imagine during the chaos of the pandemic, the recording of cause of death, it may be that they're over attributing people dying due to influenza and pneumonia. It may be that some of the people had actually died due to other things like heart attacks. And so this cause of death data is not historically very reliable. And even today, it's not as reliable as one might hope, I think sometimes. In any case, they are, however, able in most places that we're keeping data, able to count dead bodies. And so all-cause mortality tends to capture that. In the US context, this is going to capture 2/3 of the urban population. The unit of observation we're going to use is a city. In some other contexts, for some other kinds of things, sometimes people will weight regressions by city population, but here we're not interested in what's happening to the average person. We're interested in what's happening in the average city. If we were weighting by population, it would mean that New York City would have a huge, and a few other large cities would have a huge impact on the analysis. But again, unit of observation is a city. We're going to construct excess mortality. And what we're going to do is use what's called a city fixed effect and a linear time trend. We're going to exclude 1918. We show in the paper that it's robust to other ways of constructing it. So dropping other years, for example. And so this shows you the little black dots are the US cities that are in our sample. One of the things we're going to be interested in is whether they have coal-fired power plants. So these little red boxes. And then some places are getting their electricity from hydroelectric. That's these little blue circles. And so we're going to be interested in proximity to coal-fired power plants as a measure of pollution. The way you should think about these coal-fired power plants in 1915 is they were often actually located in the city, and they're emitting a lot of pollution because there's no pollution control. And they're emitting a lot of pollution out of relatively low smokestacks. And so unlike today, where your nearest coal-fired power plant might be quite far away from a city, and they have emissions controls, and the smokestacks are quite high, this is a very different setting. And so we're going to use this as a proxy for pollution, and in the paper we talk a little bit more about why that would be. Okay, so if you, and I'm not sure how many of you actually run regressions, but basically what we're doing is we're just taking all-cause mortality in city C in year T, and we're regressing it on city fixed effect. So we're allowing cities to differ in their baseline mortality rates. These are all mortality rates. And then we're allowing them to have different trends. And so, and there's an error term. So basically what that is going to do is it's going to allow us to predict mortality in that city in 1918, because again, we've excluded the 1918 observation. So we're going to just use this city intercept and the trend to predict mortality in 1918. And what we find is excess mortality is 57.7 per 10,000. So a little bit more than 0.5%. and that the interquartile range is, fairly large, right? So the top of the interquartile range, so this is the 75th percentile, is 78, and the 25th percentile is 38.5. If we take this estimate and we just multiply it by the whole population of the United States, we get 615,000 deaths, which is within the range of estimates that people currently have. We talk about the fact that it's likely to be an underestimate because in the US, rural areas were harder hit than cities. Okay, so we're going to then take this excess mortality and we're going to regress it on a bunch of explanatory variables that are measured before the pandemic. And we're going to divide cities into 3 bins, so into terciles based on these characteristics. We mostly do that because it makes the interpretation a little bit easier. You could do other things. The first thing is to note is urban is always negative and significant. And so you might wonder, well, what does urban mean? These are all cities. So urban is the percent urban in the county. So some counties are going to be very urban, like New York City, and some counties will be not very urban because they have, a town, but they also have a lot of sort of surrounding area that's rural. It's negative and significant, and I'll show you in the regression in a minute. Why would it be negative? The evidence we have suggests that what happened was these cities were more likely to get that spring wave. And then what happens during the spring wave is people get it, and then they have some partial immunity when the next wave comes. And so this is what we believe is true. It's also the case that non-pharmaceutical interventions may be important. That is, more urban areas may be more likely to adopt them. One of the things that we don't yet have great evidence on is what's happening beyond the 40 or so cities for which we have good data, right? So we have 438 cities in our data set, and we only have evidence on non-pharmaceutical interventions for about 10%. So we do look at it. We actually don't find, we find an effect that's going to be of the right sign, suggesting that non-pharmaceutical interventions might have decreased mortality. But it's not statistically significant, in part because you have to reduce the analysis to just these 43 cities. And it turns out that that's just not quite enough data to really conclusively answer the question. Okay, so we're also going to show that infant mortality and illiterate are significant, and they both increase, higher rates of infant mortality, which are this measure of pre-pandemic health conditions, and illiteracy both increase mortality. We also look at homeowner and foreign-born and find that they're not. Coal capacity is statistically significant and it increases mortality as we would expect. Manufacturing, which some people suggested could be important, is not. And then we find that proximity to military base is sometimes significant, but the timing of onset is not. So the nice thing is we can, in our context, with enough data, try and sort of sort through some of these different hypotheses. Okay, so here's the actual table. And again, what you'll see is, for example, compared to cities that are in counties with low percentages of urban residents, counties with high percentages of urban residents have mortality rates that are 18 per 10,000 lower, right? And you similarly see, places with high infant mortality have higher excess mortality. Illiteracy, you have higher excess mortality. Proximity to World War I base, if you just include it by itself, we always include urban, is significant, but when you put it in with everything else, it's not statistically significant. And then coal capacity. Okay, so here's a graph. which just sort of shows you a little bit more clearly the relative effects. So, you know, infant mortality and illiteracy share being in the top tercile has sort of similar effects. And then being in the top tercile of cold capacity is about half as big. So what we do here is basically ask, okay, if we moved everything to the lowest tercile, so if we moved baseline infant mortality to the lowest tercile, what would be the effect? And, you know, cold capacity World War I bases, and then in Part D, we also include the illiteracy. And so the main point here is, had conditions been better along these dimensions, we would have seen lower excess mortality. It certainly would not have been zero, but it would have been substantially lower, right? And so just giving you a sense of how much can we explain with some of the kinds of things that we are able to control for. Okay, so what was the upshot of all of this? Pandemic severity is related to a variety of measures of city health, poverty, and air pollution. We also explore some additional factors that people suggested they were interested in. Religious fractionalization is just the number of different religions in a city. It seems to impede, perhaps, collective action to reduce mortality. Trade seems to have some effect as well. Okay, so now to talk about Württemberg. And the nice thing is that this study is, I think, similar in its kind of construction. And so it's going to make it easier to go through, and also just easy to make some nice comparisons. So unlike the US data, this is small rural parishes. This is one of the nice things about these data is that they have high quality mortality data. GDP per capita in Württemberg is slightly below the German average, but not all that much lower. And one of the things I really like about this study is that lots and lots of people in Europe lived in settings like this. And in fact, I would love to have a similar study for the US, but we don't have the kind of data that would allow us to do this sort of study. If we did, though, it would really be super interesting. The other thing to note about Württemberg is that there are no ground battles in Württemberg during World War I. It's certainly impacted by World War I, but again, no ground battles. Okay, so this is just to locate it, although I'm sure probably all of you know where Württemberg is. And what you see here, these are just absolute numbers of deaths in Württemberg and in Stuttgart. And you can see that in Stuttgart, pandemic hits maybe a little bit earlier, and then it hits the outlying areas, which are going to be included in this larger number just a little bit later. But the peak, like the examples we've seen so far, occurs in the fall, in October or November in 1918. So here, they're not going to be able to separately look at pre-pandemic infant mortality and a measure of poverty, but they do have some very nice income data. And so this just plots for you what's the mortality rate in places with lower income, and then what happens to them during the pandemic versus medium and high income. And you can see that the increase is much higher in low income parishes relative to these other two. The other thing that they're going to do is look at cold capacity. And so here you can see that actually high cold capacity places have slightly lower mortality rates in the pre-period, and then have higher pandemic related mortality. The other thing I'll point out, this was a little bit true in the US data, but I think is a little bit more noticeable in these data, is that mortality is actually trending up during the war. And so that's, sort of just something to keep in mind, right? In terms of the fact that there's the war has been going on for quite a while, and a lot of people may be experiencing, for example, food scarcity. Okay, so similar kind of analysis. And so the mortality rate, medium versus low, medium has lower mortality, high versus low, high has lower mortality. Places in the top tercile in terms of coal have higher mortality. Here, one thing that's a little different is that they're separately looking at infant mortality, and so they're not included in the overall mortality. And a lot of things are happening with infant mortality. For example, there are just a lot fewer births during the war. And so it's maybe not totally surprising that they're not finding much. Okay, so just in terms of thinking about this study, pandemic severity is related to pre-pandemic income and air pollution, or coal as a proxy for air pollution. Württemberg is less hard hit than other states in Germany and then US cities. So the increase in mortality, 2.9 to 4.1. The paper also looks at some more aggregate data for Germany and suggests that the increase in mortality is between 5.4 and 7, depending on the specification. In US cities, it's about 5.8 per thousand. So sort of similar magnitudes, for US cities, and Württemberg being more lightly hit. And the one thing, coming back to this issue of the mortality rate rising, is if some of the people who are more vulnerable died because of the local conditions related to the war, not because the war was happening in Württemberg, but because of things like food scarcity, then it wouldn't be completely surprising that you would have lower mortality rates. It may also just be that Württemberg was just advantageous in other dimensions. So I think we don't know. Okay, so the last study that I'm going to look at is health effects in India. And again, they're going to use all-cause mortality data, and they've got 1,271 Indian towns. Important things to notice are that it's during World War I, and there's the failure of the monsoon, which led to huge food shortages. And so we know that this is potentially a big issue. Data on district officers and whether they're British or Indian is going to be important, as I showed you a minute ago. Okay, so here, the main thing that you're supposed to take away from this, I'm not going to linger on this, is that British and Indian district officers appear to be sort of distributed across districts in roughly random ways, right? So they're not looking very different. There are a few small differences, but generally speaking, when you compare them along a variety of dimensions, they look very similar. And here you're supposed to take away the same point, right? That they look like they're sort of distributed around India, roughly in a kind of random way. Okay, so this just tells you that town level mortality went up significantly during the pandemic. And interestingly, it looks like having an Indian district officer made a big difference, that places with Indian district officers had much lower pandemic mortality. And so the puzzle is going to be, why is that? But first, what I want to do is just show you, this is in terms of the crude death rate, so the all-cause mortality. And you're seeing the same kind of thing. One thing to note is that the pandemic mortality is really much higher here. And the baseline mortality is much higher here. And then, big difference in terms of having an Indian district officer. So why is it that this is happening? Well, it looks like what happened is during the pandemic, Indian district officers really ramped up more quickly than did British district officers public works employment. And that seems to have at least partially mitigated the mortality and probably partially mitigated the mortality that was related to the monsoon, but the co-occurrence of the monsoon and the pandemic meant that it effectively reduced the effects of the pandemic. Okay, so just to give you the main point here is pandemic severity is related to whether it's British or Indian, and this effect is really large when you compare it either to the US or to the estimates from Württemberg. And so the other thing I want you to take away from this is that India had very high excess mortality. The study unfortunately doesn't look at other pre-pandemic factors, although I think they probably could, like income, for which they actually do have some data. Okay, so what do I want you to conclude? Millions died, millions more had long-term effects, and high mortality from the pandemic is related to high mortality during the early phases of COVID, which I think is fascinating and warrants more work. The economic effects, the short run were negative, but recovery was rapid. And then there's this fascinating work on long run effects, which are not specific to 1918, but show some really interesting patterns. And then spatial variation is at least in part explained by things like mortality, poverty, income, and pollution. Keeping in mind that these other events are also really important.